We will start with a scenario you can read on your screen. This is a 40-year-old woman present with complaint of increased fatigue and weight gain. She feels cold all the time, decreased energy, and experiencing worsening constipation. She has bradycardia, dry skin, cold, and loss of lateral margins of the eyebrow and delayed deep tendon reflexes. This is a simple scenario. This is another scenario. A 42-year-old female presents with complaints of generalized weakness. Rather, you can read this scenario by yourself, and at the end of the lecture, in between, you will find the answer of this scenario as well. So today we will discuss about hypothyroidism. Hypothyroidism is basically an inadequate output from the thyroid gland. So there is deficiency of the thyroid hormone from the thyroid gland, of course. So it has got different causes like Hashimoto's thyroiditis number 1. This is autoimmune inflammation of the thyroid gland. There are antibodies which are called anti-thyroid peroxidase antibodies or anti-TPO antibodies. There may be formation of anti-thyroglobulin antibodies as well. Number 2, second cause is iodine deficiency, which causes hypothyroidism. Iodine is essential for the thyroid hormone synthesis. It is sometimes added to the food as well. Number 3 is the treatment for hyperthyroidism in any way, that are by the drugs or radioactive iodine, which may be overtreated by or thyroid surgery when the residual gland couldn't be able to work properly. So the next cause is medications which causes hypothyroidism, such as lithium, which is used in psychiatry. It inhibits thyroid hormone and causes goiter. Then is the amiodarone, which is a famous antiarrhythmic drug. It causes hypothyroidism or thyrotoxicosis in different scenarios. Then are the secondary causes of the hypothyroidism. The central causes, which are related to the pituitary, which excrete TSH, and when the TSH production is blocked and ACTH production is blocked, it, re it results in hypopituitarism, like in tumors, infections, vascular problems like infarction, or Sheehan syndrome, which is excessive postpartum bleeding leading to destruction of the pituitary gland. Then are the radiations due to any cause. These are the major causes of hypothyroidism in tabulated form, which divide into primary and the central causes. The primary hypothyroidism are the chronic autoimmune thyroiditis, iatrogenic, iodine deficiency or excess, drugs, infiltrative disease, transient hypothyroidism. It is painless thyroiditis, subacute granulomatous thyroiditis, postpartum thyroiditis, subtotal thyroidectomy, following radioactive iodine therapy for Graves' hyperthyroidism, following withdrawal of the suppressive doses of the thyroid hormone in euthyroid patients, and congenital thyroid agenesis, dysgenesis, or defect in the hormone synthesis. Then other central causes like TSH deficiency or TRH deficiency, or there may be a rare cause like generalized thyroid hormone resistance. So presentation for the hypothyroidism is just simple. There is weight gain, there is excessive fatigue, the skin would be dry, the hair will be coarse, or there may be hair loss as well. There is fluid retention resulting in weight gain and edema, or maybe pleural effusion or ascites. There may be amenorrhea. So there are the seven dwarfs of the thyroid disease like sleepy, puggy, cranky, achy, puffy, draggy, and frazzly. This is the summary of neurological manifestation of the hypothyroidism. One is the myxedema coma, that is the decreased mental status, bradycardia, hypothermia, hypotension, and others. Cognitive impairment like slowed mentation, poor concentration, and short-term memory. Cerebellar ataxia like gait, most commonly affected limb and speech involvement can occur as well. Carpal tunnel syndrome like pain, numbness, weakness in the median nerve distribution. Peripheral neuropathy, predominantly sensory, often painful. Myopathy ranges from asymptomatic serum creatine kinase elevation to cramps and myalgias to more disabling proximal muscle weakness. This is another scenario. This is an old female who were absent from any of the medical care for 30 years and presented to the emergency department with progressive worsening of the fatigue and confusion. You can read the scenario by your own, and we will discuss the answer afterwards. So basically, this is of myxedema coma. Myxedema coma is very important thing to recognize. It usually present in medical emergencies in our setup as well. It is defined as severe hypothyroidism leading to decreased mental status, hypothermia, and other symptoms related to slowing function of the multiple organs. It is a medical emergency with high mortality, but you can save the patient if you recognize it in time. So the clinical features are again decreased mental status, hypothermia, bradycardia, hyponatremia, hypoglycemia, hypotension, and there may be a history of precipitating illness. So here the the lady in the scenario was admitted in the ICU for intravenous depletion of the thyroid hormone. Over the next several days, her vital signs and mental status returned to normal, hence she was discharged to a rehab center 1 year after the thyroid hormone depletion. Normalization of the thyroid function, and the patient has dramatic improvement of the skin changes. You can see the picture before and after. So this is just to emphasize how it is important to diagnose hypothyroidism. There is a huge difference which can be made. So how we will investigate the case of hypothyroidism? We know the prime thing, which is the regulatory hormone, thyroid stimulating hormone, and then the thyroid gland produce T3 and TSH. So in primary hypothyroidism, the things would be same. T3 and TSH are decreased while TSH is increased because the negative feedback would not be there, so that central glands will try to push the thyroid gland to more produce T3 and TSH, but There is no production, so TSH concentration continue to rise. The secondary hypothyroidism, the things are different. T3 and T3 and T4 are low, but as there is no central gland to produce TSH concentration also low, low and low. So there are the pattern of the thyroid function test during assessment of the thyroid function, and you can just see the table. This is a very important table. You must remember it by various things. They're the euthyroid hyperthyroxenemia, euthyroid hypothyroxenemia, euthyroid T3 therapy, euthyroid thyroid extract therapy, primary hypothyroidism, subclinical hyperthyroidism, and subclinical hyper. Subclinical hyper and subclinical hypo is particularly important. In subclinical hyper, TSH is low while the other T3 and T4 are normal. In subclinical hypo, TSH is high but other things are normal, but we are supposed to treat the gland. So the management is simple for the hypothyroidism as well. This is the replacement of the thyroid hormone by oral levothyroxine, of course, which is a synthetic T4 and it metabolite to T3, which is active. There is simple dose titration by the measurement of T repeatedly. We usually measure TSH 4 to 6 weekly, that are the monthly or maybe 1.5 month. This is how we adjust the dose of the oral replacement therapy. TSH high means the dose is decreased or we are using underdosage, so the solution is to increase the dose. While if the TSH is lower, it means we are using higher dose, so the solution is to decrease the dose. This is again the scenario we saw in the start of the lecture, and the explanation is given the 1 week plasma half-life of T4, it takes approximately 6 weeks, 6 half-life before a steady state is attained and after the therapy is initiated or the dose is changed. Thank you. That's all about the hypothyroidism.